thumbs up if you can see my screen. Cool. All right, hi. So this is going to be a training I'm going to cover fairly quickly, a little bit of kind of what got us here to where we are today. I'm going to talk about how to identify an overdose and how to reverse an overdose. And then I'm going to go into some policy pieces and how to obtain naloxone, how to obtain fentanyl testing strips, as well as some things that we can do at the state level to make things better. And I usually have a longer introduction when it comes to talking about the war on drugs and the harms and how it got us here, but I feel like I'm preaching a little bit to the choir, and I kind of want to get to the good stuff. So if we have some extra time later, I'm always happy to talk about it. Most importantly, to start out with, when we're talking about overdose and overdose reversals, it's really important to center it and understand the vast majority of risks that are associated with drug use, including overdose death, are directly because of prohibition and the war on drugs. Pennsylvania lost 5,172 of our neighbors to drug overdose in 2020. We saw a nationwide spike in drug deaths. Of course, due to, unfortunately, COVID, people were a lot more alone. And we're going to talk a little bit about why it's important to be there for people. And but what got us here? What got us to 5,000 deaths? Prohibition, criminalization, the war on drugs. In June 1971, President Nixon declared a war on drugs. And of course, we know that's just a war on people, especially a war on people of color, and especially a war on the poor. One of his top aides had this to say a little bit later down the line. We knew we couldn't make it illegal to be either against the war or Black, but by getting the public to associate the hippies with marijuana, the Blacks with heroin, and then criminalizing both heavily, we could disrupt those communities. We could arrest their leaders, raid their homes, break up their meetings, and vilify them night after night on the evening news. The war on drugs has never been about keeping people safer. It has always been about criminalizing people and harming communities. Pennsylvania has one of the higher incarceration rates in the nation, across the nation. And of course, the United States and Pennsylvania have incredibly high incarceration rates compared to other countries. Some of the consequences that we saw as part of the expansion and the creation of the war on drugs was the 1986 Reagan Anti-Drug Abuse Act. This established mandatory minimums and the 1 to 100 sentencing discrepancy between crack and cocaine, meaning crack users were punished at like 100 to 1 compared to people who are using cocaine. And what was called the crack house statute. The crack house statute is now what is standing in the way of the United States establishing and legalizing safe consumption sites. Thank you, Joe Biden. The just say no attitude, which was promoted at the peak of the crack epidemic, treated drug use like a moral failing. This helped reinforce stigmatization towards drug use and people who use drugs, and stoke fear and shame in people who don't use drugs. We, of course, saw a dramatic increase in the size and the presence of the FDA. We saw growing prison system privatization and mass incarceration. Pennsylvania has a higher than average incarceration rate. Like I said earlier, the majority of people who are in jail are merely awaiting trial. 1 of 5 people in prison are in there for drug offenses. And a majority of states in this country ban anyone convicted of a drug felony from collecting food stamps. And there are a lot of other barriers that are put in place for a lot of other programs, right, that specifically keep people who have been criminalized for drug use out of them, just continuing to kind of grow all of the harms that can come from criminalizing that use. We saw, some consequences, incarceration, surveillance, and oppression of Black and brown people and people who are anti-war, a focus on punishment and blaming drug sellers or drug users rather than identifying structural causes why people might be using and why they're having risks. We also see a incredibly bad amount of fentanyl in our drug supply right now, and increasingly diluted, varied, and mixed drugs on the street. I'm not sure what it's like out in Center County, but here in Philadelphia, the dope is barely heroin, if anything. It's fentanyl, it's some tranquilizer, and it's a mix of other things. We have methamphetamine here that has PCP and a lot of other stuff in it. And this kind of like dilution and variation and like piecemealing drugs together happens because of the criminalization of drugs, and especially like the high criminalization around our borders. We of course see added health risks that come because of criminalization, as well as economic impacts. People getting abscesses, which have been increasingly really, really rough with a tranquilizer, the specific tranquilizer in the dope, homelessness, poverty, incarceration, divided families, etc. And of course, increasing overdose rates. I just breezed through a really traumatizing and awful piece of our history and current existence because I want to talk to you about what we can kind of do about this. But I think it's really, really, really important that when we talk about the overdose crisis, when we talk about drugs, when we talk about Narcan, that we talk about the criminalization aspect of it, because that is where the harm, a lot of the harm is coming from. This is one of my favorite slides. If you get me a little drunk at a bar, I'll probably whip this out on my phone and give you a spiel if you haven't heard of it. The iron law of prohibition. So I'm actually going to ask people to type in the chat. If you were, say you were 19 and your friends are 21 and you're sneaking into a bar, probably a college bar, and you have a flask with you, right? Because you can't get drinks at the bar because you don't have an ID. So you bring a flask. Would you put liquor in that flask, or would you put beer in that flask if that's the only alcohol that you could bring in with you and the only alcohol that you would have that night? Yeah. An overwhelming support for liquor, specifically rum. I would also bring vodka. Fireball. You know what? Fireball is not the worst thing anymore. I swear, it's actually kind of good. I'm 33 years old and I'm not supposed to like it, but I actually think it's good. But the point of that is, right, is if you had a specific size of something that you're able to bring past security, you want to bring the item that is the most potent, the strongest, and can be carried in the smallest amounts, right? The flask of liquor is much more potent than a flask of beer. It's going to get you a lot drunker. And if you're sharing it with your friends, you can get a lot more friends drunker, right? Than a flask full of beer, which is pretty much only going to serve you. Everclear. Don't bring me back to memories of Everclear. But this is an example of what we call the iron law of prohibition. The harder the enforcement, the harder the drugs. And so one of the places that we see this is with the increasing enforcement along our southern border here in the United States. It became harder and harder to bring over actual heroin, right? And so fentanyl, which can be made synthetically, so you don't need poppies, and is 50 to 100 times stronger than heroin. If you wanted to bring like a block of heroin or a block of fentanyl, you're going to bring the block of fentanyl, because once you get it over the border, you can divvy that up and you can get it to a lot more people and make a lot more profit, et cetera, et cetera. We saw this during Prohibition with alcohol in like the 20s. People weren't brewing beer in their bathtub, they were brewing moonshine, so that shit was stronger. And the other side of this that comes with this is that when things are criminalized and people are trying to get away with things under that criminalization, like moonshine, those things are unregulated and oftentimes a lot more dangerous. There's no regulation of how much liquor is in that moonshine or how strong it is. There's no regulation on how strong a bag of dope that you buy on the street is going to be. And so you never really know what you're getting. And that, I think, is a really important conversation to have around drugs, because it's important to know that people often don't know the strength of what they're getting. And this has just made everything more dangerous. Rant over. What is harm reduction? So harm reduction at its most basic is a way of approaching problems that focuses on reducing harms associated with risky behaviors, not stopping the behavior. It's understanding that people are going to do risky things. We do them all the time. I drove my car today. That's actually very risky. But I wore a seatbelt while I was driving so that if I did get into an accident, I was protected. I have airbags in that car that prevent further harm and further injury if I were to get into an accident. If I'm riding a bike, I'm wearing a helmet in case I fall off. I want something to protect my head. Comprehensive sex education and providing young people with condoms. A lot of people will tell you that they don't want condoms in schools because it's going to make kids have sex. Thing is, teenagers are already having sex, and it is better to reduce the harm that can come from that, whether it's STIs or unwanted pregnancy, by having condoms available. Syringe exchanges are an excellent example of harm reduction. You can't stop people from using drugs by force. You can't. The war on drugs was kind of an effort to do that, and it has clearly failed. And so what you can do is ensure that people have clean needles to be using rather than reusing the same one, which can damage the skin as it gets duller and duller, or sharing needles, which can spread HIV, Hep C, and other communicable diseases. It prevents abscesses if people are using like street water or just unsanitary water. Having clean water going out in those safer use kits ensures that people have clean water to inject with. Safe consumption sites or overdose prevention sites. Overdose death is 100% preventable when you have the tools that you need. Those tools are oxygen, naloxone, and someone who's trained. And a safe supply. Safe supply is something that I would love to see, and I struggle to think that we would get to see in America, but they've been experimenting with it in Canada, and it's incredibly effective. So all of that preamble to get us to actually training on how to identify an overdose. If you come across an overdose, you come across someone that you think might have overdosed, or a friend of yours goes out. One thing that I want to talk about is withdrawal. So naloxone will put people into withdrawal. It's basically blocking the opioids from being able to interact with their system. I'm going to talk a little bit about how long that lasts and what that looks like. But it's important to know that giving someone who's using opioids naloxone will put them into withdrawal, and it's very miserable. And so you want to make sure that someone's actually overdosing and actually needs naloxone versus giving it to someone who may be just sleeping or maybe just in a deep nod or really high, right? People have described it as the worst flu you've ever had multiplied by 10. Nausea, abdominal pain, insomnia, sweating, shaking. It is a really awful state to be in. It is better than being dead, but it is a rough state to be in. And one of the other things that's important to talk about is many people who are using drugs, not all, but a lot of people who are using drugs, especially people who are using heroin, are using it just to get well. So they're just trying to avoid withdrawal in these shitty systems. The ability to get high has kind of gone away at this point, or they're just trying to get themselves to a stable position where they can maybe go to work or do the things that they do in their everyday life. So naloxone, like I said, it blocks the effects of opioids in your system. It's an opioid antagonist. It will put someone who has an opioid dependency or who has opioids in their system into withdrawal. It has absolutely no potential for abuse. There's no possible way to use it for misuse. There's no naloxone parties. It's a bunch of bullshit. The naloxone will only work if a person has opioids in their system. It has no effect at all if opioids are absent. So I'm not going to waste one, but I could put the naloxone spray in my nose and spray it up there, and the only side effect I would have is a wet nose. It is not indicated for a person who's conscious. It is only indicated for someone who's overdosing. I say that because sometimes people get a little bit overeager and they really want to help, and they'll end up Narcaning someone who is just tired or sleeping, and it just causes a lot of problems. There are 4 types of naloxone that you'll get in Pennsylvania. The most common one is going to be the Narcan, which is the name brand one. This is one of the easier ones to use. It's a nasal spray. It works just like Flonase. You stick it up, you depress the plunger, and you wait. The other one that you'll find is a more old school model, which is a 2-parter. This is also cheaper, oftentimes at the pharmacy, but it's a bit more work to get going. You have a naloxone vial, you have a syringe or a nasal adapter, and you're basically twisting it into there, and it cracks and allows the naloxone to flow through. You can either use it as an intramuscular if you have a needle, or you can use it up the nose if you have the nasal adapter. The very, very fancy one is the Vizio. This is like thousands of dollars, but it is great for people who are not experienced in responding to overdoses or not familiar with drugs at all. It literally walks you through the process of administering it. It kind of works like an EpiPen. It's an auto injector. It's expensive. Don't buy it. But take it if someone gives you one. The other option is very old school, which is a vial of naloxone, and you'll have an intramuscular needle. You want to put this anywhere like you would do an EpiPen. So somewhere that's muscular, right? Somewhere like the top of the arms and the shoulders, the thighs, the butt, anywhere that's got kind of a lot of meat. You just stick the needle in there and plunge it. And so the most common and the ones that I'm going to be sending up to y'all are the nasal sprays. They're the easiest to use. Some people like the intramuscular ones because they have used it enough to figure out how to titrate the dose and kind of wiggle around how bad people feel in withdrawal. Don't recommend doing that if you're not experienced. So once you give someone naloxone, it is going to bump the opioids off of their receptors. There's specific opioid receptors in your brain. The opioids are attracted to them like a magnet. The naloxone is a stronger magnet. So it pushes the opioids off the receptor. And what happens then is the naloxone is attached to the receptor. Now, naloxone only lasts for about an hour in your system. So it's going to wear off somewhere around that hour mark. It depends on your body. It can be 45 minutes, it can be an hour and a half. And once it wears off, those opioids are going to be able to attach to your receptors again. And so the important thing to know is if you have given someone naloxone and you're telling them, like, I know you're in withdrawal, I know you feel like shit, just know in an hour or so, it's going to wear off and you're going to start feeling well again. And also if they were to try to use to get well and to make the withdrawal go away, it won't do anything. It can't get through the naloxone. It's just going to be a waste of money and a waste of drugs. So to identify a possible overdose, at its core is respiratory depression. It's someone's lungs are no longer working and they're not breathing. It's not like a heart issue. It is just that respiratory depression. So the signs of a possible overdose are going to be the same signs as if someone wasn't breathing, because they're likely not. Someone's skin may be blue or ashy, depending on their skin tone, especially around the lips and especially the fingertips. They will be either not breathing at all, or there'll be less than 10 seconds between the breaths. It'll be a really slow breath when you look at it, slower than like you've ever seen someone who's sleeping real deep breathe. You also may hear a raspy, rattling breathing, and of course that they're not responding. Other things are context clues. If you come across someone that you don't know and they're passed out, is there a needle around them? Is there other signs or other pieces of paraphernalia that might clue you into it? Or if it's a friend of yours and they know you use drugs, you can pretty quickly oftentimes make an assumption based on the symptoms and based on what you know. The first thing that you want to do is you want to confirm that it's actually an overdose, right? So you have someone whose lips are blue and they're unconscious, and you want to say, like, think to yourself, like, is this another issue, another medical issue, or is this potentially an overdose? Or are they just tired or sleeping or really high, but not actually overdosing, right? Because we don't want to put people into withdrawal if we don't have to. So there's 3 steps to confirming an overdose. These go very quickly when you're actually in person. The first one is verbal. So look at them and speak to them and see if they respond. This is usually a, hey man, are you okay? If you don't get a response, you move on to physical. So you may give them a shake in the shoulder, like, hey man, are you okay? Like, give them a good shake. And if you don't get any response from that, another thing to do is tell them that you're going to hit them with Narcan if they don't respond. Sometimes this will pull people out of it because they've been Narcaned and they don't want to have that happen again. The third way to confirm, the third kind of next confirmation, is a painful stimulation. This can be done in a couple different ways. One of them is to take your fingernail and shove it underneath their fingernail and push. It hurts. If you've ever gotten a splinter under your fingernail, hurts like a bitch. Another way is to ball up your fist and use your knuckles and rub them on their sternum really quite hard. This also hurts like a bitch. Any way to use painful stimulation to try to get them kind of jerk out of what may be a really heavy high. If they don't respond to any of these and you think that they might be overdosing, they're considered unresponsive and it's your job to take action. So step 2, after you've confirmed that it's an overdose, I do recommend calling 911, but I'm going to leave that with a lot of caveats, right? Because 911, often cops come and cops are not helpful in these situations. I recommend calling 911 if you are unfamiliar with responding to overdoses, if you're new to it, or if you're alone, especially, because there may be something more complicated health-wise that's going on that you might not be able to handle. There also could be that you don't have enough Narcan to reverse them and you need more, and For the most part, EMS usually has it, or they have an oxygen tank. I work with a lot of folks who are living in encampments on the street and using drugs, and they're very confident in their ability to reverse an overdose on their own, and they're not calling 911. I ended up having to call 911 after the second dose of Narcan. I didn't feel comfortable enough because the guy still was not breathing. And I did not feel comfortable enough as just a naloxone trained person and trainer and not a fully medical professional if that were to keep happening and he were to keep not breathing. I wanted to get oxygen in him, and I wanted to get more oxygen than I could provide. When you do call 911, I recommend saying, my friend has stopped breathing and I can't wake them up. My friend passed out and I can't wake them up. Something that is a very specifically medical thing, right? Like, not my friend's overdosing, because like the operator's thoughts are going to go to like illicit activity, right? So my friend has stopped breathing is a medical problem, and that EMS can respond to, and that police are likely not going to be able to help. The my friend part, it's a compassion thing. You get a better response when it's when people feel that it's more personal. It sucks, but it's true. You want to ensure the safety of the scene, because you're going to be kneeling down to address them. You probably were already kneeling down, but the safety of everyone involved is really important. So if you see any needles or glass on the ground where you're going to be kneeling, you want to kick those away, especially if you're wearing closed-toed shoes, or find another way to push them out of the way. You can be assertive and assign tasks if there are other people with you or other people around. You can ask someone to start the timer. Can someone else call 911 while you're responding? Is there anybody else close by who's trained that can help if needed? You can, as a first responder, people look to you oftentimes for how to help, even just by like taking that step in responding. And so you can bark orders at people and they're generally going to do them. You can also tell people to go fuck off if there's a lot of people surrounding and gawking. This is not a spectator sport. People gawking, taking pictures or videos are not fucking helping anything. You can tell them to get lost. As a first responder, you have implied consent to respond to the best of your ability to a medical emergency where someone is non-responsive. So that just, you've done the best you can to wake them up, and now you're responding to the best of your ability. Step 4 is to actually administer the naloxone. So you want someone or you to start a timer on your phone. I like to do it for 3 minutes, and then I kind of reevaluate. And you're going to also check their airway. You do this before you give CPR as well. You kind of tilt their mouth open and just swoop your finger through and make sure there's nothing large that's blocking the airway there. And then you're going to administer the naloxone. So you're either going to use the nasal spray, you're going to do the IM injectable, you got that fancy Vizio and you're going to use that. Whatever it is, you're going to administer that. And the next 3 to 5 minutes suck. They suck. It can take about 3 to 5 minutes to work, especially with the stronger drugs. So the stronger fentanyl and carfentanil that we're seeing, it's taking longer and more naloxone to work. So in those 3 to 5 minutes, you are either giving rescue breathing or you're putting someone into a recovery position. And this is why I had you start a timer on your phone, because time doesn't mean anything at this point. It's going to be very hard to track. Rescue breathing is if someone is not breathing. If someone is not breathing, they are actively, oxygen is not getting to their brain, and that can lead to long-term damage. And so they're basically dying, and you can keep them alive, which is an incredible gift and an incredible thing to be able to do. Of course, you want to check their airway first, or again, you're going to tilt their head back like the picture shows. You're going to pinch their nose, and you're going to put your mouth kind of over theirs to create a seal. So don't be shy. You're going to create a seal, and you're going to push one big breath in. And while you're doing that, you want to tilt your head a little bit to the side, and you can see their chest, right? And just look, and it should rise pretty significantly when you push your air in. You're doing that just to make sure that you're getting the air into the right spot, and that the head is tilted far enough back that it has a path. I have somewhere for you CPR masks that can go with the Narcan kits. I always keep one with me. I had to use it the other day, and because of COVID, I'm very grateful. It is a one-way valve or one-way thing on a piece of plastic, basically. It's like a dental dam with a one-way passageway through around the mouth. So you just place this over their mouth with a printed side up, and then do everything else. But this is protecting you from any fluids or germs, mostly. I don't think it's perfect, but it's a good way to protect yourself, especially if, you know, people are wet or something's going on or have vomited at some point. You know, it's a nice way to keep things clean. You can also use a mask or a t-shirt, which will allow the air to go through, but will prevent some bodily fluids from transferring. It's not as perfect. And you are going to be doing this until you administer naloxone or they start breathing. So you're going to do it every 5 seconds and then take a minute to check and see if their breathing has changed, if they've started breathing on their own. This is also a time where you can again try painful stimulation. A really good chest rub will sometimes start to help bring people out of it. With those knuckles and a fist, pressing them right onto someone's sternum and rubbing up and down. And you are keeping them alive at this point, which again is an incredible thing to do. If they are breathing okay, even if it's a little slow, but they seem to be breathing on their own, you're going to put them in the recovery position. If you had a college experience like me, you had drunk friends sometimes that would fall asleep when they were drunk, and you'd put them on their side in case they threw up. You are doing the same thing here. You want their head on their arm, ideally. If you can place their arm underneath it, have their head like leaning on that arm. And you just kind of want them mostly on their side in case they do get sick. There is a way to do it that is easier by kind of using some leverage. So if you prop their knee up and like pull it towards you, the opposite knee, it can help you roll them over if they're bigger than you are or heavier. And for that 3 to 5 minutes while they're in the recovery position, all you're doing is watching their breathing, making sure it continues, seeing if it gets any better, maybe some painful stimulation to see if you can get them up. After 5 minutes of rescue breathing or recovery position monitoring, the person should ideally start to regain consciousness. If they do not, it's time for a second dose of naloxone. We are now seeing with fentanyl, people needing 3-4 doses. I always recommend having at least 2 on you if you have a kit. And it's a rinse, wash, repeat, whatever. So it's administer naloxone, and then you go back and you're doing that 5 minutes of monitoring or rescue breathing. If they don't regain consciousness after the 3rd dose or even the 2nd dose of naloxone, especially if you're inexperienced, you know, this is why we call 911, because we might not have the tools that are needed, or it may be something else going on at the same time. I want to say trust your gut is really, really important in these moments. If you don't feel like they're okay, if you don't feel like their breathing is enough, if they have one little breath and you don't feel like it's enough and you think you should be doing rescue breathing, do it. If you feel unprepared to handle the situation and you want to call 911, call it. You have to trust your gut in these moments. And you're always following every dose with rescue breathing if they're not breathing. So that took longer than I thought it would. And it feels like a lot of information, but it actually goes really quickly when you're doing it in person. It's a lot of information, but the steps are really clear. And so usually in a training, I would flop myself down on the ground and we go through it, and you can see that it only takes a couple minutes. But just for the purposes of Zoom, I'm going to go through those again. So the first thing that you're doing is you're identifying an overdose. You're looking for blue lips, ashy skin, ashy fingers, someone who's non-responsive, not breathing, or breathing, really struggling to breathe, maybe rasping even, kind of grasping at air. You're then going to confirm it. You're going to confirm through 3 steps, which is verbal, physical, and painful. None of that works. You have an overdose, especially if you've seen other signs of an overdose, paraphernalia, you're in an area where drugs are used, etc. You're gonna have someone call 911 or call 911 yourself. Again, I recommend it for people who are new. You can take that with a grain of salt. I feel safer if I've gotten to a certain point and I can't revive that person with medics coming. I'm also fairly lucky in Kensington that they don't usually send cops with the medics. Sorry, I'm trying to go through these quick. You're gonna safety of the scene. If there's needles on the ground, kick them out of the way. You are going to administer naloxone. You're going to, for 3 to 5 minutes, do rescue breathing or the recovery position. And then you're going to continue as needed or go to aftercare because the person woke up. So it's only a couple steps. It's a shit ton of information. But when you're actually doing it, these first 3 steps are very, very quick. You're just quickly making sure that they're unconscious. You're like handling the scene and getting down on your knees, kicking needles out of the way if there are any, kicking glass out of the way if there are any. You're pulling out your kit and you're starting. Those 3 go very quickly. The most important is administering naloxone and rescue breathing or recovery position. That was the practice. And so ideally someone has now woken up and they are out of the withdrawal, they're out of the overdose and they're alive, which is incredible, because without your care, they could easily be dead. You want to do the best you can to inform the person what happened. Sometimes people wake up and they're pretty pissed off because they feel like shit and it's hard. You want to try to get a little bit of information to them, which is, hey, I'm so sorry. I did have to Narcan you. You weren't responding. I know that you're sick right now. I know that you're in withdrawal and it sucks, but the naloxone is going to wear off in about an hour and the drugs that are still in your system will start to kick in and you won't feel sick anymore. I don't recommend that you use again before the naloxone wears off because you're wasting your dose, you're wasting your money. You can't get high and you'll have more opioids in your system when it does wear off, which means you could overdose again and need Narcan again. I always like to say, stay with them until EMS arrives, if EMS arrives, or, until ideally, best case scenario, until the naloxone wears off. That's not always possible. But ideally ask them to stay in areas where there are other people. So if they do go out again, fall out again, there's other people around them to know. You don't want them going somewhere alone for the next 2 hours. But if it's a friend of yours, stick with them. They can use other drugs that are not opioids to help with those symptoms. Marijuana is great for the nausea. You're not supposed to mix benzos, a little coffee, cigarette, that's all fine. If that helps with their symptoms, it's totally fine. Just a really quick note, sometimes things happen that are unexpected, of course. One thing that we are seeing is fentanyl muscle rigidity. So if you go to give rescue breathing and you can't even tilt their head back and you can't open their mouth is super tense, do the naloxone first. Once the naloxone kicks in, the muscles tend to soften and then you can do rescue breathing. You can also, in a true emergency where you cannot get their mouth open and you need rescue breathing, you can do it through their nose. It's weird, but you can. Of course, if people have wounds, you can protect yourself with gloves. I recommend gloves in your kit, basic wound care stuff. So the first recommendation that I have is for people who have insurance, especially Medicaid. If you have insurance, going to your pharmacy, you can get naloxone unless, obviously, if you don't feel comfortable doing that, don't do that. But this is a way to make the insurance companies pay for it versus the health providers or volunteer groups pay for it. And oftentimes it's free. If you're on Medicaid, it's free or $1 or $2. On my insurance, for some reason, it's $40 and it used to be free. So I don't get it from the pharmacy because I'm not going to spend $40. But if you have good insurance and it's covered, getting it from the pharmacy is a great way to just get it, make the insurance company pay for it, and then have more resources in volunteer groups and outreach groups who don't have the cash to buy it. A distribution site, sometimes the counties do distribution of naloxone. Sometimes super dope community organizations do distribution of naloxone. Another way to get it is Next Distro. This is great if your pharmacy person's really nosy or you always run into someone there that you don't want to have to talk about this with. Or there's not a distribution site happening and you don't know how else to get it, you can go on the Next Distro website. They will mail it to you for free and discreetly. There is an effort to legalize fentanyl test strips at the state level. The bill numbers changed, so I don't have the bill numbers right now. I think they also haven't been introduced yet. There's also legislation going around that is in a co-sponsorship memo point right now. So there's not an official bill number. It's not an official piece of legislation, but legislators are talking to each other, trying to get each other to sign on. That would legalize syringe exchange programs, which are currently also illegal in Pennsylvania, with 2 exceptions, Philadelphia and Pittsburgh. Safe consumption sites, I can talk about those for hours. You would never get me off the Zoom call. Safe consumption sites save lives. There's no ifs, ands, or anything about it. They don't promote drug use. They don't increase drug use. They actually keep neighborhoods safer and cleaner. There's a currently very large battle going on here in the United States about legalizing safe consumption sites. I call them safe consumption sites because not all drugs are injected, and a safer consumption site should be available to anybody who's using any drug. And there have been iterations of SB 675, which was a previous bill number. Again, I don't know the new bill number yet, which would try to, it has all these extra limitations to providers of buprenorphine, which is a maintenance therapy treatment for opioid use. It helps people kind of replace opioids with a treatment program and a medication. And it's great and it's super fucking effective. It is the gold standard of treatment, and they are trying to make it much, much harder to get. And anytime they try to make it harder to get, we do not want that.